Elizabeth, you're.
Yep, I was muted. Sorry. I'm going to share my screen and just make sure you all can see it. Are you seeing it?
Yes.
Okay.
If you can put it in slideshow view.
Mm-hmm. All right. Well, thank you for having me from the Health Department on behalf of Dr. Maura Rossman, the health officer. We're glad to be speaking with you all, and we're privileged to be serving our community and ensuring their public health in this crazy pandemic. It's unlike anything we've ever imagined, but this is what we trained for, and this is what public health, it piques what we are here to do. So we are happy to be a leader and contributor to what our county is doing. So what does public health really do? We essentially, oops, I'm going to move my chat box. Sorry, give me a second. We serve the public trust to keep those that live and work in Howard County safe. We look at water and safety, we provide education, we offer preventative services, we improve access to care however we can by either health insurance or Medicaid, rallying the troops around Medicaid to provide additional support. And we enforce public policy and laws that protect our health. This is our organizational structure as it is before COVID. And you can see that the health officer has a big role of ensuring that the programming and the operations throughout the health department are in service and working correctly. You can see that we have an environmental health, access to health care, assessments is looking at data and communication plans. We have the Bureau of Health Services that provides direct patient care services. Population health looks at community programs to protect the health and prevent chronic disease. And then we have behavioral health, which looks at our mental health well-being and ensuring our providers in the community have the resources and patients have access to mental health services. This is me in the middle, and I kind of oversee now in a transformation all the programs in terms of providing consultation. I highlighted the bureaus that have been affected by COVID in yellow, and essentially 50 to 90% of their staff were reallocated from their traditional duties into COVID-related tasks, just to show how broadly it has affected our health department. And this all started on the stark day of March 15th, which is burned into my brain as our first call about a long-term care facility having a case. And we were the first county in the entire state to have a long-term facility case, which started like a boom, and then we haven't stopped running since. This is how we've transformed our health department from our pre-COVID roles has transformed us into an incident management structure. And you can see that there are a lot of people involved, but then there are a lot of operations that are not our traditional 8 to 5 jobs. In such, planning has taken on many different aspects, looking at what we needed to do. So we were behind the ball on some things, and then projecting what we need to start planning for in the future. So you can see multiple activities that were medical surge. We worked with partners, vulnerable populations, and then we transformed these into operations. And there were 5 key operations that we set up very quickly and started to manage. Outbreak mitigation and disease surveillance was really looking at our long-term care facilities and helping them manage the disease that just started with a boom on March 15th and started going throughout all facilities because staff were shared at multiple facilities. Contact tracing was a huge endeavor. And I will say for the outbreak facility, 11 of our staff were involved with that. Contact tracing, over 21 of our staff were recruited and put into contact tracing immediately. We developed a call center to answer all the public's questions and then to triage where people could go for additional resources and support related to COVID. That was 8 staff. We then set up a testing center, and that was 14 of our staff. We set up a PPE distribution for our community providers, mostly our long-term care facilities who did not have the volume of PPE materials that they needed for daily care. That was 9 staff. And then we set up environmental health to answer essential business questions and environmental surveillance of disinfecting and questions that they had in small businesses. Is that a question I'm hearing, or just keep going?
Please keep going. I think it's somebody's background noise. I'm muting everybody.
Okay. Where we became resilient and we innovated during this pandemic, I was asked to just touch on some of the things that we had done. Oh, my laser is not working. So again, we innovated our patient and client practices as we could not see as many in the facility. We instituted telemedicine, which we had for our school-based wellness centers, but we had not used in our normal practice. We did some virtual site inspections for our environmental health inspectors who usually went on site to inspect different facilities, but now for health safety reasons and for social distancing, we changed over to virtual site visits and inspections. We instituted WebEx calls for all of our case managers that normally did in-person one-on-one case management. We instituted WebEx calls and had to train all of our staff for using technology to converse and help the recipients of the technology utilize the technology. We started offering drive-up services. So it was drive up for your depot, drive up for your STD testing. You know, we became very intuitive that we could not have all these clients coming into our building. We became very innovative in our program. We started offering online classes for those one-on-one teaching sessions for, you know, a new mother needing lactation classes or guidance. We started online classes. We created enrollment portals for much of our MCHIP and our ACECU so that clients didn't have to come in and sit at the window with a staff member. We instituted a program where we were able to distribute smartphones. So many people did not have smartphones, and as you know, the technology is mandatory that you have a phone. So we distributed some smartphones. We created hundreds of new partnerships, and we are grateful for being in Howard County for the friends that we have developed over the years, but those partnerships really paid out in this pandemic. We have multiple community agencies, many from the vulnerable populations and disability and foreign-born populations in Howard County, Latino populations, Hispanic and African-American populations, the long-term care facilities. I think I know every single assisted living and nursing home director by first name. We all have exchanged cell phone numbers. We have close ties to the correctional facilities, dialysis centers, many of the retail industries, especially the larger factories. We know the directors or the owners by name, and many of the primary care practices have been reaching out to us, and we've developed even stronger relationships. Testing centers, Hopkins has been Howard County General has been our friend again in numerous occasions in helping us with urgent testing. The urgent care centers have reached out to us, and we have developed partnerships to expedite testing or provide them supplies and vice versa. Clinicians, we have been providing them PPE, labs throughout the state and even abroad who have been facilitating our test results. We have developed relationships with them. And lastly, from a health department that was mostly on site with, I think there was 2 employees who teleworked on a regular basis. Now 90% of us are teleworking. And so we developed teleworking policies and as such to help our workforce continue to do the good work that we were doing pre-COVID, but then also master our COVID tasks. We've done broad outreach to vulnerable populations. This has been heightened by social distancing, quarantine and isolation necessities, but Howard County Health Department has prioritized the communicating and the connecting of individuals to community resources, such as our contact tracers, utilizing Care App, and contributing to the county's new online resource center, repurposing our hired multilingual case managers as contact tracers, and then finally utilizing medical outlets to message and target populations. We have targeted community education and outreach that has been provided specifically to local businesses, the African-American population, and other vulnerable populations throughout the community. And often we are collaborating with our other key county agencies to require their assistance to reach those hard-to-reach populations. Throughout the health department's COVID-19 response, we've created communication materials that have been inclusive of our county's diverse languages, cultures, and health literacy levels, often consulting, again, the culturally diverse partners that we have built over the years. Our challenges have been many, but we are persevering. We have teleworking, I assume for all of you has been a challenge, but training our workforce to be comfortable with technology, and then monitoring productivity and work as supervisors remotely, building a specialized workforce. So contact tracers, outbreak management, we all needed specialized understanding and skills to manage COVID-19 and all the aspects of it. Maintaining updated knowledge has been my hugest challenge because the data and the guidance is changing daily. Science is coming out very quickly. Managing our data in terms of our outbreaks, our testing, our need to vaccinate the population, gathering all that data, managing that. The data systems that we had were not able to keep the capacity of volume that we were doing, and so we've worked very closely with the county DTCF to develop databases that could hold the volume and update it as we need to. Challenge to maintain our non-COVID services in the middle of most of our staff doing both COVID and non-COVID roles. And then ensuring our mental health and well-being throughout all of this, not only the communities, but our own staff who are burning out and suffering their own losses within families of COVID. In the community, finding PPE supplies and staffing for everything has been limited, and that has been a challenge. Educating the community and the individuals who are affected by COVID has been a challenge, having them understand what is going on when it is very hard to understand. Compliance, as you all know, with the face mask, social distancing, and hand washing has been our hugest challenge, and emphasizing to the public that this is a real disease and that just basic preventative measures could help stop the spread. Gaining the public trust, which has been hard. We have won in some areas. We still have yet to win that trust in some populations. And basically reaching those hidden populations has been a challenge, as it is all the time in disease management. Our greatest challenge will be the vaccination. SARS is devastating families all over the world and communities. There's over 71 million cases to date and over 1.6 million deaths. It spreads easily through respiratory droplets, which is the biggest challenge. There's no drugs to prevent the infection before or after the exposure. So vaccination is actually key to stopping this pandemic and preventing the infection and reducing the severity and disease for anyone that gets that. This is just a very high level. I did not get into many details about the vaccines, but vaccines train our immune system to recognize a disease-causing part of a virus. And traditionally, they either contain weakened virus that is grown in culture, unlike mRNA, which is coded protein that was manufactured. The new technology is a person receives the genetic material, which is created by the pharmaceutical company, mRNA. It encodes the viral protein, and then we use these genetic instructions in our own bodies after it's injected into our arm muscles in the muscle cells to translate them and produce more of this mRNA protein, which is coded for the spike protein in the situation for SARS-CoV-2. This spike protein then is put out into our body, and we develop our own antibodies against this. And so this is a very new technology that is groundbreaking. It is a very safe technology. There's no infectious part of the virus. It uses our innate protein machines, building machines, to build the protein, and then our normal body's antibodies to build our own antibodies. It does not interact at all in the nucleus of the cell, which is where the DNA is. So it will never get incorporated into our DNA. Once the mRNA is made as a protein, in fact, it actually is destroyed after several weeks in our body, and then breaks down as we are making more and more ourselves. It's very efficacious. So the mRNA literally just provides the instructions for our bodies to do what it normally does, and we do it well. And the immune system recognizes the protein as not belonging to build that immune response, and it's boosted each time we get the booster dose, which is why we need the second dose, since this is a new protein and our body needs to rev up our system to develop those antibodies. So this is just a slide that shows that there are differences between the mRNA vaccine and traditional vaccine, but the biggest difference that I want to clarify is that traditional vaccine takes literally up to 6 months to create, because it has to be grown in culture in a hen's egg, and then that viral protein that was grown is then the liquid is harvested and purified, and then that is made into a vaccine. This mRNA vaccine is basically like getting a password to a computer code, and you enter the password, and then the mRNA is created, and then it is injected into our body, and then our body does all the work. We make more protein, which then creates the antibodies. So it is a much quicker process to manufacture, but it is also a much quicker response that our body can make in order to develop antibodies quicker. The brilliant part about this is anytime that the virus mutates, a new code just needs to be generated and vaccine can be redeveloped very quickly. So this is brilliant science that is not new. It has actually started back in early 2000, even before that. It's just because the mRNA was so unstable that they weren't able to perfect this type of vaccine. Now they code it in a lipid molecule, which the fat kind of hides the mRNA when it's injected, so our bodies don't destroy it. And then once it's taken into the cell, the fat layer is dissolved so that the mRNA is exposed, and our body can then go to work using those instructions.
Elizabeth, I'm sorry to interrupt you, and I also know that this is what people are very, very interested in. Can you just take 1 minute to wrap up so then we have time for the other two panelists?
Sure. So who's going to be vaccinated? There's priority groups, and it's basically healthcare workers in hospitals are first, and then people at risk, which includes the long-term care facilities. Critical essential workers are next, and then the general populations last. And this was made as a recommendation from the advisory committee. In Maryland, there's about 850,000 to 1 million people in just groups 1A and 1B. In Howard County, there are about 1A, we have about 13,000 people. And then in 1B, we have about another 122,000. And so you can see that there are a lot of people in Howard County that need to be vaccinated. And we don't know how much vaccine we're going to be getting. So it is a slow process, but it's a phased approach that we use to vaccinate people. And this is from the CDC. And we are following a vaccination plan that is addressing 1A and 1B first. Then we move on to group 2. And so there will be a slow uptake in the beginning because we don't have a lot of vaccine, but as the vaccine starts rolling in, we will have plenty of vaccine for the population over the next couple of months. And so if anyone needs more information, these are some resources.
Thank you so much. There was a lot in there and a lot really good overview of the mRNA component. Thank you.
Sure.
Now we'll move on to the other important side of this in response is human services, social services. So Jackie, would you like to take it away?
Yes, good morning, everyone. What a pleasure to be here to talk to you about this important topic this morning. Many of you know that the Department of Community Resources and Services is our human service agency. What many people don't realize is much of what we do, most of all of what we do, we serve everyone across the lifespan. We are not relegated to one sector of the population, and most of our services and resources are available to anyone who needs us whenever things happen in their lives. So many of our services are not income driven, or you don't have to income qualify. So what that has meant during this pandemic time is that people who have found themselves not traditionally needing help from anyone have found their way to us because of an identified need, whether or not they've lost their job, their business, whether or not they have been ill, they have a relative that are ill. What we have been able to do is provide. Our focus really has been providing those critical human service needs around food, shelter, clothing, essential needs to be able to keep people stable and be able to keep them supported through the dailiness of their lives. So what we have seen is that though the impact on the business of human services, and I talk about it that way because our business is people. And we have to be nimble enough in times of an emergency, whether or not it's an impending snowstorm or it's a pandemic. We have to be nimble enough to respond depending upon what the role is. So clearly, health has the primary role in a pandemic. The hospital, the health department, and we play a supporting role in filling those critical gaps. And so there are a couple that I want to highlight for you. So, our basic human needs work has been tremendous around the numbers of people who need food. Food access has been critical across the lifespan, from feeding our children and our families to weekly meals provided to vulnerable adults. People who are vulnerable just because they can't leave their homes, or vulnerable because of income, or any other issue that has come up in their lives. So we are feeding people weekly. We are providing the basic services around clothing and shelter. So where we would normally do a coat distribution to those who are most in need for whatever has come up in their lives because they are vulnerable, we are finding ourselves providing coats and clothing for families, and holiday time, um, making sure that people have the things for their children that they want to be able to, just celebrate the holidays in a healthy way. So we are having to respond very nimbly to a much broader demographic than traditionally seen. Another thing that we've done is we have utilized technology significantly to increase our reach to people. We have, and I have to say, the pandemic has shown us that the human service, social services, and public health sectors, as many of you know, have been woefully underfunded in many areas. And for us, technology was one of them. Because we are a people driven business, we were used to doing very hands on things. So we, like the health department and others, have had have had to focus intensely on training our staff to utilize technology to meet the needs of people in the community. So we have utilized technology to do check-ins on our older adult population. Our Parents as Teachers program continues to run supportive services for our families remotely by using computers and Zoom and WebEx, all of those things. So we've been able to do that. We have increased the utilization of technology to really focus on digital equity. So we are investing in computers and technology that will help reach children who don't have internet access or don't have computers so that they can learn. So we're coming alongside the education system, the school system, to make sure that those gaps are filled. And we're working to make sure that our older adults are not socially isolated. By putting computers in their hands and getting the technology and the internet service to them, we can do wellness checkups. We can work with them to make sure they're not socially isolated. We can keep them engaged in classes. We can make sure they're getting their prescriptions filled. We're linking them to the health department and our other providers. So all of those things are happening to allow us to then also use technology to collect and understand the data for where the most pressing needs are. And then we're able to zone in to neighborhoods and regions and populations and create circles around those neighborhoods to make sure that those families have the services they need. So then that leads to the next one, which is outreach. We then use that data to target outreach, making phone calls, helping to make sure that people are getting to the services they need and are enrolled in the services that they need. So we have to do that by being nimble in terms of the true diversity of our community. So what we've also been able to do is to tremendously ramp up our access to information in multiple languages. English, of course, everything was always printed in English. Well, we know we need Spanish, we know we need Chinese, Korean, Chin, Hindi. So most of our all of our populations are we're making sure that they are being reached, that people are not being left out. So we're using trusted sources to be able to then take that information in the relevant language and work within those communities to be connectors to make sure that no one is left behind.
Jackie,
So
I'm sorry.
sure.
I'm sorry.
No, no, that's okay. I know that we're short on time, so I want to I'll wrap up really quick
Perfect.
right now to let you know and I know that there are important questions that will come up, but there are areas that we know in this conversation there's just been disproportionate impact. We have been tracking that. We know that women have been disproportionately impacted, people of color, Latino populations, people living with disabilities. We know African American populations. So we are targeting resources and working with the people on this call and in the community to make sure that we're closing gaps, and we're working on the vaccination plans along with these partners so that we're able to leverage what we have done to make sure that we can get the vaccinations out. So I'm happy to answer more questions, and I'll yield the rest of the time to get in our last speaker.
Oh, that's wonderful. Thank you, Jackie. That was a great deal of information. And now, Nikki, would you like to take us home, I guess?
Hi, good morning, everyone. It's so nice to see everyone today on this. I guess it'll be a snowy day. We'll see. There's so many of you here today. I have some former board members on, some current board members, and some volunteers on many of our committees. So thank you for your service. I've been asked to talk a little bit about the philanthropic response to COVID-19 and speak a little bit about community innovation and as well. So quickly, I'll talk about the philanthropic response. Sort of three main points I want to make. One, we gave quickly, and we gave a lot more money than we gave before. I'm excited to say that the Horizon Foundation, as your community health foundation, we quickly responded to COVID in May and got out $1.1 million in emergency funding to our healthcare community. I often think about philanthropy as a bridge potentially to government funding. Certainly the CARES Act funding and the PPP funding was more in terms of total dollar amounts, but philanthropy was able to get out quickly into the community in May so that we actually were able to bridge to when the other funding came through from the federal government and from the county. In total this year, between COVID and our strategic priorities, the Horizon Foundation gave out over $2.4 million. Traditionally, we give about 5% of our endowment, and this year we probably are giving out over about 7% of our endowment. So gave quickly, gave more. The second is we gave together. I think I saw Dee on, and I know a couple of board members on from the Community Foundation. The Horizon Foundation joined forces with the United Way of Central Maryland, the Giving Circle of Howard County, and the Community Foundation of Howard County. We really created a one-stop shopping for our nonprofit community. We did not want them to have to go to multiple philanthropic funders in order to seek funding for basic needs. I'm very excited to say that we've given out over $600,000 together, again, to support basic needs in the community, housing, food insecurity, utilities, and childcare. So we've given out money to about over 40 critical nonprofit organizations. So gave quickly, gave more, gave together, which was really great. And then finally, we leaned in, at least at the Horizon Foundation. We were already doing a lot of things that were really important in terms of healthcare issues in our community before COVID that became critically more important after COVID. Jackie talked about the health inequities that we have seen based on healthcare issues and also social determinant issues. We've leaned in on that issue pretty significantly. We've leaned in related to mental health to expand mental health services in our community. And we've leaned into end-of-life care, which unfortunately right now is something that is vitally important, and for people to express their healthcare wishes before that they can't speak for themselves. And then Elizabeth asked me to sort of also talk about what's changed for the better. We've had an incredible community response, but what's changed? And I'll just focus on a couple things that really have already been said, but I'll just emphasize them. One is the level of community collaboration and innovation that happened. I think I saw Bruce